Thanks a lot. Great being here. It's really a great collection of people, a lot of familiar faces, a lot of great smiles, and I really applaud you for going above and beyond. It's not only what you do in your practice, now you're continuing medical education to even know that much more about what you can continue to implement where you are and what you do. So great to have you here. So we're trying to figure out how to get these big boy prostates to act like the pediatric prostates. Get back to your youth, shrink that guy. So there really is a new paradigm. There are some new things that need to be known about an old thing. You know, BPH has been around for some time. Everybody in the room here, you're part of SUNA. So you understand benign prostatic hyperplasia. You've seen people work with it in your offices. So we're familiar with it. Why treat LUTS earlier? This has been your main issue of patient coming in as a man with symptoms, having this, and should we be on top of it perhaps even earlier and understand its potential for risk down the road. So there's a paradigm shift, and education is important. So we've seen slides like this. There's our youth where our prostate gland is a little bit smaller, and the flow through the prostatic aperture is less resistant. But I go over with patients with this all the time. Your ability to urinate is your bladder pressure minus your prostate resistance pressure. So it's A minus B is your flow. So my flow is a little bit less. So that just means, well, your bladder is less in pressure or your prostate is higher in resistance. A minus B is your flow. It will always be A minus B is your flow. And as this prostate gland encroaches and gets bigger, the bladder's response is, hey, I want to get bigger too. The bladder's a muscle. It's a smooth muscle. And its response to obstruction or resistance is to increase in strength. So as the prostate resistance increases, the bladder musculature pressure increases. So they kind of do this. They do a dance. So prostate increases in resistance, then bladder pressure starts to go up. Prostate, bladder, prostate. So as this bladder increases in strength, it also increases in changes in its musculature, which leads to frequency and urgency as it wants to go, go, go. It starts to become an Arnold Schwarzenegger bladder as a result to increased prostatic resistance. So it's in the gym. It's a smooth muscle. It's supposed to contract against low resistance. Now it has a resistance, so it's started with 10 pounds, now it's up to 50 pounds. I was putting the 2 plates on. It wants to go to 150 pounds. It's trying to do what it can to address the resistance issue. It's progressive, and we see a correlation with age. So 30 and 30 and 40 and 40. So 60% of men, as they approach their 70s or 80s, will have significant symptoms secondary to prostatic obstruction. So here's the guys, and they're talking. So what do you think? How you doing? Hey, Joe, did you go in the pool? No, I saw you. So it's, you know, they talk about this stuff because they're guys, and they do share this commonality of carrying prostate glands and having a potential for risk for prostatic obstruction. So we need to meet their address. But the number one reason for male referral to urology is some prostatic obstruction. When you start looking at the prevalence of this condition, how many people live in the United States? About 325 million people live in the United States. 40 million with BPH symptoms. So that's literally 15% of the United States has prostatic symptoms with obstruction. So, you know, a third to seek help. 60% of these gentlemen are on medications. 30% discontinue. 30% are watching. About 3% have actually gone to require procedures for intervention and treatment. So it's really the tip of an iceberg of treating a very common condition with some issues at hand. So this is a common. So when you're a younger guy, you're just kind of stepping back. You don't really need to go. We see a lot of bears in the woods, you know, leaning forward. If you go to the games downtown, you can kind of see, you know, where people are. And this is me, the kitty cat, about after 4 cups of coffee in the clinic about 11 o'clock. I don't know if the patient has more or I have more. We're talking about it, and We both try to take care of business, but these are the symptoms we're trying to treat. But this is, this bladder starts to run your life. Now we can talk about, big presentation about OAB, but you're starting to get OAB with BPH because these bladder changes and muscular alterations as a result of resistance occur. And the bladder does start to change. So LUTS really means you're having physiologic changes in the bladder musculature and sensors, from sensors to contractions, a whole bit. So if you're having LUTS, you're having bladder changes. And changes are changing your life. So again, schematics and pictures are key. I can't be in a clinic without having pictures, because I always got to refer to the picture, because that way you kind of highlight, where is it, what is it, what is it causing, and so if you always have diagrams in the office. So here it is, and we're talking about your prostate. Here's the location of this. As this gets bigger, it's pinching off. This is how it looks when it gets bigger. The channel gets narrower, and you got the A minus B, and that's why you're having their slower flow as this resistance is going up, and your bladder's trying to catch up, but it can only catch up so much. So as a result of chronic resistance change, the bladder will alter and trabeculation comes in. So you see the happy guy on the left side, or on your right side, and the happy, or not as happy guy on the left side. So the changes lead to a thing called trabeculation. That's thickening of the bladder. This thickening is a result of response to resistance, which is to its favor for a while, but then leads to decompensation. So it starts well, but doesn't end well if it progresses and continues to progress. And people's lifelines on this are different. Some go pretty quick, some take a long time, some don't get there, but some do. We want to help those that do and help prevent those that would ever come to. So this parallels smooth muscle in the heart. So the smooth muscle contraction in the heart, it's not a skeletal muscle. You don't think your heart to contract. You don't think your bladder to contract. It's not like firing the deltoids and holding up your arms as hard as you can. It's a smooth muscle. And it responds to resistance. So you talk to some cardiologists, they just drool on this. Yeah, don't forget the Frank Starlinger. This is how the heart works. So work and resistance lead to hypertrophy. And dilatation and less contraction reduce ejection fraction, and cardiac failure occurs. So this same muscle response, cardiac, smooth muscle, to resistance from a valve and cardiac failure and heart failure, same thing happens in the bladder. Smooth muscle response to resistance, trabeculation. Same words are used. Here's this Frank Starling's curve. What does it look like to a sonogram? Looks like a flow study. It does. So you have an arc, you have your flow, you have your initiation, you have nice peaks initially with normal and with exercise. But then you start to have things like myocardial contractility dysfunction, heart failure, and failure and complete cardiac myocardial dysfunction and loss. So this similar curve is actually a similar curve that can be extrapolated on bladder. So trabeculation that we use a lot as far as in urology, as far as what can happen to a bladder, is the same terminology they use in the heart too. Yeah, the heart can be, as a smooth muscle, trabeculated and not work as efficiently to contract well for heart as a result of resistance. So let's take BPH and turn it into something else, because this is really where the cornerstone is. It really should stand for bladder preservation health. Bladder preservation health. We've got to nail this one down. And this is the paradigm shift. So as far as, prostate. No, how about bladder? And what can we do with the bladder to preserve the bladder to function as well as it can for an indefinite time? So here's the flow study. So we see here, and we're familiar with this, right? And we got the curve. So a nice bell-shaped curve means you got a nice rise in your flow pattern of stream. Urine comes out, minimal resistance, nice strong arc up and down. And you quantitate this, and this would be, as far as numbers, an average, and maybe getting into a little bit of concern and perhaps need for intervention or treatment. But this is how we at least measure to some degree. That's why it's important in the office. It's good, yeah, PVR is important, but this flow rate's really showing us a little bit on what's happening on this curve that could project to this bladder not responding well down the line in the future that we want to prevent. So it is important. It's not just getting a PVR, but looking at this flow rate. It's important dynamics to obtain. So as far as the personal journey, so my kind of call on this was, well, what can we do to, because I really think achieving an open prostatic channel will preserve prostatic health, or preserve bladder health. So our BPH preserve bladder health. Can we do it? If we just get an open channel, we take the pressure off the bladder responds. So but what would what patient really prefers coming to the office? Do I really have to be on medications? Is there a way to get off medications? And if you can get off medications, what do you have to go through to get off medications? Could you do something that would be painless, successful, sustainable without general anesthetic? Is that possible? So I've toyed with this microwave and Protiva for a decade and stuff. But what I found out was you look at the articles and how people did, they were good out of the blocks. And so when people are doing this out of the blocks, it was fine. But they didn't have much long-term success, and it was uncomfortable. And if the patient's uncomfortable and the doc sees the patient's uncomfortable, everybody's uncomfortable. That's not a win. So it's like, we treated for a while, then they were really uncomfortable, so we stopped. And so not a lot of treatment, not a lot of energy was delivered. So prostatic blocks are key. So the same prostatic block that you did for doing a biopsy is good, but you got to go up a level because you want this gland, if you can, completely anesthetize. And there's a way to do it. So you do your standard prostatic block that you would do for prostatic biopsies. But if you go intraprostatic with a needle, once you place your initial for the biopsy block, you go intraprostatic with local anesthetic and deliver all the way up to the bladder neck. So really the whole bladder neck to all the way back to the apex is completely anesthetized. When that's completely anesthetized, you've got a complete prostatic block. So you can give heat. And if you're pain-free, you can give a lot of heat. If you give a lot of heat, you're going to have a channel. And that's what we were able to see. So we did this in the office, and I kind of got excited about it. I thought, this is going to be my little, I'm going to get on a pedestal and just talk about this. And so people are interested. So I gave presentations at a variety of meetings. Let's see. Let's go back one here. Yeah, so complete presence. So let's see what it shows. So the goal was, could you create the channel? And this is pictures of patients who had the microwave therapy as well as Protiva in the office that I gave talks about. And so it's important to kind of see, can you create the channel? Because if you create the channel, you can have a good flow and protect the bladder. Build it and they will come. Create the channel and they will void. And Lord willing, void now and void indefinitely for thereafter. So with the block, I started, had an opportunity. I'm blessed to do some presentations at a couple AUAs and the like. I never got to the NCAA, but keep trying. So the one issue about this though was we could do this procedure, and it was great for urination. Everybody's excited about that, but it was opening that bladder neck, and you couldn't preserve ejaculatory function. Now I'm going to kind of read this, but it was most often assumed that if you had prostatic procedures for BPH, as a consequence, ejaculatory dysfunction would occur. But it's generally accepted that if you had improved urination, it would negate the loss of the ejaculatory capabilities. And so you go, okay, so let's go to a procedure so we can be off the meds, but you're going to urinate better, but you may not be able to see the ejaculate at the time of orgasm. But you're going to urinate better. What do you think? And the guy was, I just want to urinate better. Okay. And that was the general assume that's okay. But nowadays, we have advancement, and there's additional therapies that are not only allowing you to open the channel, but also preserve the ejaculatory function. Because some guys were pretty distraught. It's like, it's just not normal. It's just odd. It's just, where does it go? And so, well, it goes back in the bladder and then you void it out. But that's just not normal. Okay, I got that. So is there a way that we can preserve everything, right? These therapies were not altering erectile dysfunction, but it was altering ejaculatory function. So could you do that? And so I was like, well, there's going to be. And so then newer therapies are coming in that do just that. You can treat the gland, you can create the channel, and you can preserve the ejaculatory function. So that is hot. That is good. And you can still do that with the same in office, no general anesthetic, painless, comfortable, good result, good outcome. And so now I've drifted from put the door on the others and looking toward live personally. That's what I chose. And you want to be, if you can in anything else in what you do, you want to be an expert in what you do. Now, of the docs you're working with in your offices, you just want your guy or your gal doing the best they can with the best outcomes all the time. So it doesn't have to be one specific procedure, but do what they do and do it well and get great outcomes. For me, for in-office, I'm really loving this thing right now. So I really see I can hit all aspects of care to achieve all goals to preserve bladders, to avoid better for an indefinite period of time, and we'll talk about that more. The big paradigm on this is also in AUA. The emphasis before has not been to the extent that it is now for the changes that occurred. So early detection, early intervention is key because we want to not allow bladder dysfunction to occur. Prevent progression of bladder dysfunction at early intervention. Elimination of prior recommendations for BPH procedures to be delayed until medical management fails. Because that's been kind of what you did, right? The guy came in, how you doing? I'm growing pretty well. What are you on? Are you on Flomax? Okay. Stay with what you got. Yeah, just stay. It's going good. All right. So stay. So that was like what you did until they came in and go, how you doing? Well, I don't know. Going, I'm getting up a little bit more. Well, do you want to continue? Yeah, I'm fine. But we got the Y chromosome. We always like, there's X and Y. Y stands for why do I need to do anything? and I get that. So, but sometimes you need to. Sometimes you got to bring that out a little bit. And so it's like, well, maybe this is going to be better for your bladder if you're starting to lean toward some risk of your bladder working harder, because we've got to protect this bladder preservation health. So sometimes we have to ask the question a little bit more, and we got to invite the fact that there's other things you could potentially do, because the pill thing is just easy, but it may not be to their advantage long term. It really is. It's the easy thing, but it may not be to their advantage long term. And we're finding some stuff out about medications now. And so we're going to get on that as well. We'll allude to it. Collecting information that is validated as IPSS score is very important and very good. And it doesn't have to be too laborious. And as a person's waiting in the before they're coming in, before they're coming in to come into the office, sometimes they can fill this out. Or at times they sit down with the medical assistant, they can fill this out. Or they can take it home and fill it out and bring it back later. But it is important to kind of document where they stand as far as their numbers and their symptoms. But this blue arrow at the bottom is very important too. Would you be interested in learning more about a minimally invasive option that could allow you to discontinue your BPH medications? So this needs to come up. So is there some type of therapy that could be offered? If it would be offered, would you be interested? And this is important now in what we have available to make patients aware. So there are some therapies. That way they get the option to move beyond their medications and get helped along that way. Because 50% of the guys are really not satisfied with their medications. They drop out due to side effects or progression of the symptoms that they see. When asked, when they circle that circle, they do circle it often. About 75% are really interested. Really, you have something available different that's not too intrusive. You're not going to hurt me, are you? And I can urinate better, and it's going to be okay. And the answer is, yeah. We have this. They're concerned that 85% of what they're seeing outside are not being offered, but from primary care, because they have so many other things on their plates for them to also talk about this. So get it to us, and as this team, the SUNA team, you can educate your population. Yeah, there's some therapies we can do that can be done, and they're minimally invasive, and they can be very helpful, and we can be off medications. And there's good reasons to be off medications at this time. So a lot of people have been on alpha blockade for extended period of time. I'm there. And so the issue is, why be there with some of the side effects that can occur? Well, a lot of people don't have side effects. Flomax has been out there for a long period of time, and we haven't seen much side effect profile of significance. Yeah, if you're lightheaded and dizzy and things, that will come due early and feel like that's not for me, I can't do it. But this hit the press just recently, this whole dementia thing, and it's a big deal. So again, it's the first article about this, so it's not a plethora of things and information. But it does raise the question, is it safe to continue on certain types of medications if there are good therapies available that are in office, no cut, no incision, no heat, no side effect profile for erectile dysfunction or ejaculatory dysfunction? Where does this stand between medications, especially with dementia? And when you mention this, it's hard, because everybody here has parents, have had parents, or parents are now deceased that may have dealt with central nervous system issues, Alzheimer's, dementia, et cetera, and we're concerned about it in ourselves, and we hear that there's a potential therapy that could also add to this or exacerbate this problem. It is a concern. So with this hitting press and this is hot off the press from last year, January 2018, so you have to have a response. So urology, what do you say about this? So Kaplan's a pretty good authority on BPH, and so he had to address this. So it's a little wordy and kind of hard to read, so we're just going to highlight it. So whether we are doing our patients a disservice by long-term medications for essentially a quality of life issue, can we really justify taking a medication or often multiple medications for bothersome voiding symptoms, particularly now in an era where we have numerous minimally invasive alternative therapies, as well as safer and more effective surgical therapies? We got to rethink and redefine what we do in urology with patients on medications for bladder preservation health. What about the 5-alpha reductase inhibitors? Well, we know to a degree they have some erectile dysfunction issues. We know also that at a certain percent will get breast enlargement and nipple tenderness. What about metabolic symptoms, syndrome, depression, and harmful behavior? There's 2 articles here about suicidality and depression as a result of 5-alpha reductase inhibitors. And there's also metabolic syndrome, alterations in glucose and profiles as well. So there are long-term sequelae being on these medications that we sort of hand out like candy a lot. I can take this, I can be fine. A lot of people don't have symptoms like that. It probably doesn't see any side effects. And a lot of people are not going to say, I think I'm feeling a lot, I'm losing the keys a little bit more than I used to. Must be that. So these are things we got to think about a little bit. So that's why we're extending this new paradigm of staying on medications safe. Not everybody has to come off medications, but we just have to think, are there other alternatives, because maybe there's going to be some sequelae that could occur, especially if we have other therapies that may be a nice alternative to. So medicine, they work fine, great first-line thought, but perhaps long-term medications isn't where we need to place people on. Maybe not an indefinite therapy it has to be sine qua non, it has to be, well, a lifer on this. Well, maybe there's other things you can do. And patients want to know. They have access to these phones. They're getting techie. They're probably more techie than me. I had a hard time getting these little things loaded up earlier today. But people want to know, and they're seeing things that are available, and we want to talk about it and be able to bring it to the plate and talk sensibly. So the big question is, if not medicines, is there really procedures that can be performed in the office? No general anesthetic, no cutting or resection tissue required. Can they maintain erectile function and ejaculatory function? Can they have the same sustained results that resective procedures can? And can it be minimally painful and performed in the office? And this one does. This one really, I'm hot on this right now. It's just having a good run maybe. But I've been doing this since I segued out, I've left the microwave and Prostiva about 2 years, about 1 year and a half ago, and this has really had a nice run. And it's just doing well for patients, so I'm just smiling about it. And it's because the guys are smiling. I almost wanted to pull this out and play the video. I had a guy the other day, and he comes in the clinic, and I go, how'd it go? And he goes, oh, it went great. I go, so your urinate's fine? Yeah, off the medicine's good. And I go, I don't know, do you want to tell other people about it? He goes, sure. I go, okay, hold on. And I pull out my phone, I go, you want to tape it and I can show it to other patients? And they go, sure. And so I turned my video on, and he just talked. And it was just so cool. It's like, I go, well, so how'd it go? Well, it went really well, and now I can urinate better. This just was a fun dialogue. And it was raw. It wasn't like, okay, you got your suit on, now you're ready, so I'm going to ask you this question, and you're going to answer, and then, see what you say. No, it was just like, tell me what you felt. And did it hurt? Was it uncomfortable? Yeah, it was a little sensitive, at the time. But I did see some blood for a couple of days afterwards. But man, I was urinating really good, and I didn't have a catheter. So it was good. So I'm seeing a lot of that. So that's why I'm kind of raising the bar a little bit for urologists. Get involved in some of these in-office things. Resume, Urolift. They're good technologies, and they're helping me. And we're creating the channel. And for the guys, we've got to get a good channel to preserve their bladders. If you have a good channel, you got a good bladder for an indefinite period of time. And I think it's a very key good thing. So this is innovative. It's FDA approved. There's been about 17,000 of these performed. They've got data on AUA that will be launched in May. There'll be 8-year data. The 7-year data showed that only 20% of people who've had this procedure done have required anything else. So once done, the question is, well, how long does it last? The typical transurethral resection, creating a channel, was supposed to last around a decade. So that was kind of the, okay, if you do a resection procedure, you went the distance, you did, how long should that last for? And usually about 10 years. So all the laser, green light, cyber laser things, the goal was, could you get close to 10 years on that? Because that's the goal, right, to get to the resection things. But this is going to play in about a couple more years, pretty close to resection data, just doing a little in-office procedure where you're attacking that procedure open, attacking that prostate gland open. So we heard about the no-hit. So this is kind of a little demo on it if you've not seen it. So you're going with a scope and you're pinning. You're going extracapsular, intraprostatic lumen, pinching that tissue open, creating a channel. Oh, this video is going to work. So this kind of shows a little demo of it. So you're going extracapsular, and then you're going to compress it on the inside. So you're not having to cut, resect, or remove anything. You're preserving the bladder neck, which allows ejaculatory function to be preserved. Because at the time of orgasm, the ejaculatory mechanism, the bladder neck contracts and the ejaculate gets propelled forward. That's sort of the before and after. So here's kind of a live, picture before and picture after of creating a channel with the tissue pinched away. So sometimes people are like, yeah, I like the nice resected, smooth lined channel. Well, this doesn't create that, but it pinches the tissue open. The goal is open. Get open. Get open and save the bladder. They will have a little bit of odd sensations, like, I feel a little awkward when I urinate, I feel a little pinch, it's kind of odd. And that happens for about a week, two, sometimes up to as much as 3. Depending on the procedure, if it's a bigger gland that we're doing this on, they may have some blood when they urinate, and we'll put a catheter in. We'll say, we're going to keep a catheter. We're going to keep it overnight. We show them how to cut the extension to deflate the balloon. The balloon's removed, and out the catheter comes the next day. But they're back to normal activity with a pretty short period of time and sustained ejaculatory and erectile function and sustained relief. This is just some of the evidence showing, quick evidence to improvement versus medications. And you've got a couple of zeros there for any type of ejaculatory or erectile dysfunction. So preserve the good stuff, create a channel. And this just shows some durability from when this slide was made. Now it's out to 7 years ago to 8 years in May. So as far as getting this cleared, and so guys are getting pretty excited about this as far as what they can do, and Mama Bear likes it too. So that's why it's kind of cool. But this is what we're trying to prevent. We're trying to prevent this bladder going bad. And so this is a netter picture showing all the things that can happen: bladder diverticulate, bladder stones, trabeculation, all secondary to prostatic obstruction. Now, not every bladder that ends up having trabeculation is the cause of prostatic obstruction. There's neurologic causes that can be mutually exclusive, but they're kind of like Venn diagrams. You can have bladder conditions, you can have prostate conditions. They overlap sometimes in the mechanical effect. But prostate has a big primary role as far as leading to resistance that leads to bladder changes that can progress. We know it's a progressive disease, as we alluded to earlier. So we're going to segue a little bit and look about what do we do with guys in retention and transmission. So who's familiar with the prostatic stents? Good, good. So
way back in Minnesota in the 80s.
Okay, that was Urolum. That was Urolum. And that was like, ooh, not Urolum again. So that was used to put this in as like a little. It was what they were doing for. It was wire. The wire was in there. The goal was you put that in, and everything will urothelialize. Yeah, we'll get a nice coverage. It didn't. Oh man, it wasn't like they thought it was going to be like the coronary vessels, man. Put that in. That cardiac is very happy heart now. You've got good blood flow, but it didn't work. It didn't play well with urine, and so it didn't get a urothelial alignment, and you had to sometimes remove those guys. Oh my goodness! So the idea of bringing up prostatic stents again just gave the chills for everybody. So everybody was like, No. And so this thing hit the tread, and I washed it for a long time. Went to AUAs and go, yeah, it looks really good. Yeah, it does. Yeah, it looks pretty good. I wasn't going to touch that, but it was playing pretty well. And the concept was it was not mesh, it's not wire, it's not permanent. So this thing is placed just in the prostatic fossa. So it acts like a catheter, and there's a balloon that sits in. It holds it in position. This little flange that sits on the outside. In the outside meaning it's in the urethra beyond the sphincter. So this kind of shows a little bit better. The goal of this spanner is to restore natural micturition to men in urinary retention to really assess their bladder function. So let's say you got a guy in retention. He comes in with a catheter. You did a trial void. The trial void shows that, all right, he didn't void. What to do? He's already been on medications. Put the catheter back in again. So send him to urodynamics. We got to check the bladder physiology. We got to see, what pressure is the bladder able to manifest against what type of resistance, because maybe his bladder's shot. Maybe do a transurethral resection, it's not going to work because his bladder's not going to work. So that's kind of the rhyme and the reason that we work with every day in the clinic, and you see. So, but guys don't like catheters, and you can't tell, can you really urinate or not, because you got a catheter. So what if you just put a catheter just in the prostate gland? And that's what this is. So this deploys just as if you were putting in a Foley catheter. So you advance this in, you're going through the urethra, you're in the bladder, you inflate the balloon, you snug it up, then you take off the extension. So like you're going to launch a satellite. So you got the big rocket that takes off. You get rid of the rocket blast, which is the rest of the catheter. And the only thing that sits in is you deploy this little module just in the prostatic fossa. So it's a little straw that sits in the prostatic fossa to obviate resistance. So if their bladder is able to have a normal contraction and void, if they didn't have prostatic resistance, this would be to some extent how they would void, at least not against resistance. Now, again, they're urinating through a straw. It's a 20 French catheter. It's a 20 French, you've seen 20 French catheter, you've seen the little lumen on that. That's what the urine's going through. So it's not going to be a gusto flow, but it's going to be a flow. And we can see to what extent are they able to urinate with this in. So all of a sudden you have a person in retention, and now you have this device in, and you're seeing is their bladder able to respond in order to empty to a degree. If they are able to a degree, then that says, okay, if this is then out, are they able to do okay on medicines for a while until we go to some type of therapy? Or are they going to be able to do well on medicines, eventually come up on, you have all these different alternatives. Sometimes to be with the spanner for a period of time allows their bladder to recover some of its potential function, which is easier than having a Foley catheter. And if you get 100 guys in a room, I really think if you get 100 guys in a room, you say, it had both, because we did this when we were doing microwaves. We always put these spanners in after the procedure instead of Foley catheters. Everybody was happier with the spanner than they were with the Foley catheter. It's just irritating more. It comes out the urethra, out the tip, the whole length of the tube. The other benefits of this, less urinary tract infections, because with a Foley catheter, you have a total inside-outside device. So bacteria just climb up. Everybody knows about urinary tract infections associated with Foley catheters. With a spanner in, for some reason, that distance between and not having an externalized extension of that catheter leads to less infections. There are a lot of data supporting spanners in place, less urinary tract infections. And so, and how long can you keep it in? We've kept it in on a couple of patients a couple months. Sometimes you have somebody that needs a big-time procedure, needs a resection procedure, and they have a Foley catheter in, and why don't we just change it out to a spanner? We've done that. So the time they're coming in for the procedure, they have the spanner in. You take the spanner out and do the procedure and carry on. So it's a good way to assess bladder function outside of urodynamics. It's a good alternative to a Foley catheter in preparation for a procedure down the road. There's a string on the end that allows you to remove it. The string actually allows you to deflate the balloon, which allows you to then remove the device. You can leave the string all the way out to externalize, so they can take that out at their convenience at their time. Or let's say they, for some reason, they can't go and they had a little clot that got in the tube. Oh my goodness, what do? Pull the string. And this is one of the things like you're pulling the lawnmower to get it started this spring. Like, pull that guy, come on, get that thing out of there. So it's just a delicate pull. Make it snug until you feel a little pop. That little pop means a little pledget that held the fluid into the balloon just deflate it, and then a little small tug allows you to pull out the entire device. So not a big to-do, but you have to make sure they know what to do, because a lot of people do some crazy things with strings. So we got to coach them on that. But sometimes they just don't want to see the string. That kind of wigs them out. So you can cut it flush. That just means you have to go in with a scope. You have to go in with a scope to get the string on the stent when you're taking out stents for ureteral stents. So you can do the same thing with this string too. You can leave it on the inside so you don't have to see the string. But then you have to put a scope in to grasp it to remove it. So consider. I think it's a really good option for patients with this. So it's just a new tool I use it for prediction, right? It's a new concept for prediction. It bypasses, and patients prefer. We've done about 120 by 130 patients now. We presented at one of the meetings at North Central, and it's pretty novel still, but it's a really nice thing to do. Yeah.
Is this latex or vinyl, or what's it made out of?
Good question. I think that it is non-latex. It's clear. So is it silicone? Yeah. Yeah. Great. Nice response, man. Just turn around. I got to tell you. But it seems to, and sometimes some people will feel it. It's not like I don't feel a thing. Some, but most people feel it to a degree. Yeah.
Doesn't the string allow for bacterial entry?
Yes, I think it would, right? Because they have it inside outside, but it's not like a Foley catheter extension for some reason. The data supported that. We've seen that. We haven't been as thorough as far as mapping out the exact number of people who've had infections with the device in, but at least the published data is very favorable, at least comparing to Foley catheter. So I can't say string and bacteria risk. I can say published information as far as spanner versus Foley catheter data. Yeah.
I'm having a hard time understanding how it doesn't affect the sphincter, so they still have control.
Right. So let's go back and let's look at that. So the way this sits, I can see it on the screen. So I'm going to stand over here. So it's just, so the balloon's here in the bladder, right? This just sits in the there's different sizes. So depending on the prostatic volume and the prostatic length, you place a different size. So you got a really big gland, they have 8. If a big, but not that big, 7. So all the way down to 5. They have even 4s, but mainly 5, 6, and 7. But big glands you can put an 8 in. So anyway, so that just sits here. There's a little, same string thing, goes through the sphincter. So the sphincter it coaps, so it's not going to be affected by the string going through the sphincter. So that's why there's no continence change. And then this little phalange here sits in the bulbar urethra. And that allows it to hold its position. Otherwise, it wouldn't hold a position, right? Because if you just had something there, it's going to migrate into the bladder. But with this here, this wants to pull back, this is going to pull up here.
You have the scope on at some point to measure.
Oh, to measure? Or by prostatic ultrasound. So you can just get it, on transrectal ultrasound, you get, the urethral length is such. Now they have a device, Spanner actually has a device, where transurethral, you're placing this thin tube through and you pull that snug, and that's supposed to measure that length. And I looked at that and I go, I'll measure with ultrasound. But there are transurethral instrumentation to try to establish that length. I just haven't been that comfortable with it. I think that's a little awkward for the guys when we're doing that. And you kind of got a ballpark. After you've done enough, you go, this is a 6. This is an 8. This is an 8 for sure. And so there's different ways to really place that kind of by feel once you've done enough. Everybody comfortable with that? And you can send this. See, I'm blessed with such a good staff, and Kathy Halgado is my nurse, and she's just been a gem. I mean, you're only as good as your nurse. I mean, that's the bottom line. And she has been such a highlight and a blessing in my life. And so, if you want, if it's okay, maybe if Kathy's willing, you can always give her a call and ask, what's Smith doing? And we can fill you in with anything we're doing, and I can talk to your doc or whatnot and see if whatever you want to implement. All right? Yeah. All right. So it's not UroLift or nothing, right? There are other procedures, and other procedures work very well. And so not all candidates are for urolith procedures, depending on the size of the gland too. And sometimes you can do bigger glands, but you can't through insurance. So insurance really wants them to be 80 grams or less, and they really want this documented. And it really is tougher on a greater than 80 gram gland. And so there are other therapies that are something you need to look for as far as body habitus. And maybe they don't have good, I mean, I'm not going to do this unless I can get a really good prostatic bladder. I want guys to feel as little as possible, ideally nothing. A lot of times we even rated pain scores, and we say, what's your score? 0 out of 10. And a lot of times when the prosthesis and microwave, they were sleeping. I go, that's a 0. And so, same thing we could try to achieve on the urolift. But you just want, so you want prostatic access in order to do the block. But green light, cyber, bipolar, everybody pretty familiar with these, performing these and having your docs perform these in the office and the like. They're all very good procedures, done well, good procedures. So you want your guy doing good work. What's his outcome? If his outcome's good, do it. And if you're getting good results, do it and continue to do it. That's what you want to see done. And getting involved in my lean on this, and perhaps the whole reason for the talk is the new paradigm. Get involved before the bladders want to tweak out. And get involved so that there's options for them outside of medications, which may have effect. Resume should have been paralleled there back with urolift as far as in-office therapies that are very effective. And we're going to start getting involved in that sometime soon. So this is the Resume equipment here. So it's a lot like Prostiva was. It's transurethral placed heat energy that allows the tissue to, over time, essentially disintegrate. Instead of radiofrequency energy heat, it's actually radiofrequency energy changing to vapor heat, so water heat that causes tissue to essentially disintegrate. When that heat hits that tissue, the first response isn't open sesame, but rather crunch. So because that tissue's response is increase in swelling. So there's always going to be a temporary squeeze before open. And so it's not like, yeah, coming in and getting that done. You'll be urinating well in a week or two. No, it's going to be a squeeze. It's going to be harder. So those guys need a temporary catheter or spanner because there's going to be a period of time where it's going to be hard to urinate. Sometimes intermittent catheterization, not preferred, but you just have to understand these are elements that are going to be a transition. A lot of times you'll hear, it's just 2 days, 2 days you'll be fine, but they'll struggle for a while because they're against resistance for a while, until that has changed. Usually 2 to 3 months, usually 2 to 3 weeks, but usually up to 3 months you're seeing progressive improvement. So what do resection therapies look like? So bipolar. So there is the old transurethral resection of the prostate gland, which is important and good, and that's historic, but that wasn't a current energy, and a lot of people would have TR syndrome because you couldn't use saline and you'd get absorption of water, and water led to dilutional hyponatremia and potential procedures. This is a big, so hospitalization, CVI, big deal. Bipolar allowed that energy to be confined to the loop, so you didn't dissipation of energy, and you can use normal saline. So very safe resection procedure. This is a very effective therapy resection-wise for men that require resections. This is sort of what it looks like on the inside. So what does that look like when they're doing that? So this is what you're trying to create. You're trying to create that channel. Most of these procedures will require a catheter for a period of time, usually 1 to 3 days. A lot of times we're getting to the point where we can get this done outpatient, and most of the time outpatient at even surgery centers. My big thing on CBI. So everybody goes for a resection procedure. Everybody that I have undergoing a resection procedure goes to the recovery room with a continuous bladder irrigation, so they got fluid going through, and they give them Lasix. So I'm going to stop the irrigation within about 15, 20 minutes, and then once that's off, have they still got a good flow going? Yes, because we give them a diuretic, so they're making their own natural irrigant. And so so the transition is wake up, and then the waking up bit is the waking up fully and being aware, and if they bear down, could what was nice and pristine and clear go to Zinfandel, then to red, and you don't want to get the Heinz ketchup. So you just got to have that irrigation for that transition, and then for a little diuretic. So those are little things that I've done that have been beneficial for transition. Every urologist has their own thing they do. So this is showing like a laser transrectal resection. We'll see if we actually get the video on this. We didn't get the video, didn't play. It was kind of fun. I was hoping to be able to see, have you watch and see what vaporization does, and you can see the channel being created, but unfortunately that didn't play. This is something you may see down the road as far as a new and improved. This is aquablation, so this is another way of using water vapor, but not as heat, but just high intensity. So the best analogy of this is when you see celery in the store, and you go into, oh, it's nicely sliced. I got my cut celery, and I'm going to take this. Well, how did that celery get cut? How did it get cut so nice? How did it get so nice and crisp? And is there a guy back there going, at the end of the day, he's like, oh man, I got to use my left arm next time. So they're not cutting that in the back. You know, they got a machine that cuts and dices. No, they got this high pressure water beams kind of, you know, and so it goes on a tread, and then it just goes right through this water beam, precisely cuts, wraps, and goes. So this high intensity water stream can be effective now inside the prostatic lumen to hit tissue, to disintegrate tissue at a controlled space. And so big glands, so the one that used to be, oh, this is definitely open prostatectomy, this is definitely robotic prostatectomy, too big a median, no way, you can't do, or I like to resect this guy, but he's just too big, and it's going to take 2 resections, and I don't know if we can do it effectively. This may come into play because it's really effective. So it's out there. We're yet to launch here in the Western burbs locally, this therapy, but we're looking for an opportunity. You're going to see this play down the road. This is one of the newer upcoming therapies because you can contour it. You can map out exactly what you want to resect with this water pressure robotically, sonographically. So it's just connected and confined, and you visualize. It's going to be good. But this is today. This is bladder preservation health, a new way of looking at BPH. So instead of it's a big gland, it's there and it's annoying, it'll give us LUTs. Yeah, it's a big gland, it's annoying, and it's there, and we got to preserve the bladder. We don't want to get to the right. We want to stay to the left. If we start to get to the middle, we want a lot of bells and whistles. Preserve the bladder, address the prostate. Medicines are okay. Try to use them as transition. Great Band-Aids, try to not be permanent. There are some things that are coming out about these medications that are not in the best interest of the guys.